Good afternoon, everyone. I'm going to talk a little bit about some work that our lab has been doing during this COVID epidemic within the hospital NYP operational capacity. And so this work is being done in the lab that Sarah Collins, Rossetti, and I share around clinical decision support. My name is Kenrick Cato. I'm an assistant professor at Columbia School of Nursing and also appointed in the emergency department. And also a bulk of the modeling was also done by Chris Naplin, who is in our lab. So I'm going to talk about primarily about work that we've done looking at how to support the scaling up of surge capacity in the hospital. And what we've used to do that is a model that Sarah and I developed called healthcare process modeling. So, So the bulk of this work has been funded by the Concern Project, which stands for Communicating Narrative Concerns Entered by Registered Nurses. And it's funded by the National Institute of Nursing Research, NINR. And so the need that the hospital has during this epidemic is basically to be able to dynamically classify the characteristics of beds. So to understand what type of patient is in what bed. We know that this information is gathered in the EHR, and there are some EHR specific configuration issues in tracking patients. So things like the fact that individuals have to manually enter the information. When we're updating beds, it might be the case that these things are changing frequently. And so when we think about the addition of beds and then also the repurposing of beds. And so because of the volume that's occurring right now, there's concern about the process, the manual process kind of breaking down. And also, there is a issue thinking about just being able to validate that the manual process is actually working. That when people enter information into the HR that they're new beds, there's a need to validate that that actually has happened accurately. And so these are our use cases. So from an operational standpoint, so what you see here on the left. The hospital system as a whole needs to understand what we call the foundational mapping, which is to understand what beds existed before the surge. This needs to be able to be synced with admissions, discharge, and transfers. And you can see in the table here, we are trying to understand, on the facility level, the hospital level, whether it's an ED or non-emergency department bed. We also need to understand whether the bed is adult or pediatric bed, and then the care level. And then finally, we have the bed type. There are beds that are kind of holding area beds or hallway beds that are beds outside of rooms. And then finally, if it's an actual physical bed or if it's a virtual bed. And the virtual bed concept is basically a location where they put people into to understand where someone might be going next. So for example, someone might be physically in the emergency department, but they're waiting a bed in the inpatient setting. So they create a virtual location to understand who those people are. And so I mentioned the other use case, the second use case is that what I mentioned before is identifying the changes during the surge. So identifying beds that have been moved from one type of bed to another type of bed. And so, one example is right now we have surgical suites where they're no longer doing surgery in those suites, and they've actually moved beds into the surgical rooms and are using those. And then finally, to track new beds as they come online, and also ventilators. So We are using what I refer to as a healthcare process model, which basically looks at how clinicians are interacting with the system to identify what type of bed. And so these, for example, we're looking at patterns of documentation of observations. And so we apply, we're using a machine learning based approach to classify what type of bed that is. And so we apply and validate these features with clinicians and make sure that, you know, what we're learning makes sense. And then we understand that these interpretations are proxies for the actual surveillance that would be done by a human being. And so it's really important to point out that the healthcare process model is based on the patterns of actual clinician behavior. And incorporated in this clinician behavior is the individual's kind of clinical expertise, the decisions and knowledge that they have as practicing clinicians. And so for the bed surge model, as I mentioned, it's a classifier, and the method that we followed was basically identifying the features. And you can see here on the screen the list of features that we looked at, which were flow sheet entries, and for folks on the call that aren't familiar with the EHR, flow sheets are the area where nurses typically put a lot of their observations. So we looked at flow sheet entries for a bed in a 24-hour period, and also looked at the total number of beds, looked at other features like how often the bed was occupied, the total time the bed was occupied. And then our process reduced those features, and then we looked at the outcomes, bed type, virtual unit. We had known to train the model, we had known locations and other to compare that to. And so the model, the type of learning we did ended up being a multi-class logistic regression, and we trained it on 20 randomly selected days of visits to train the model. And so one of the reasons that we picked a logistic regression model was this model needed to be operationalized into a report. So once we built the model, we converted the model into SQL so that this report could be run at whatever interval is necessary, usually a 24-hour interval. And so this type of learning lent itself to that. And so this is just a matrix to show some of the performance of our model. And so the first box here, first table shows when we're training the model. So you can see the recall for the different clinical settings are on the bottom here, and the precision is on the right here. And so you can see that we had pretty good metrics on training, and then when we validated the model, we found that it was a pretty good performing model. So, and so there are issues that we had when you think about there's certain areas, for example, when you look at obstetrics, there are, you know, subclasses within obstetrics, like the nursery, for example, that make it a little more difficult to classify. But overall, we're very happy with the results, and we have a very well-performing classifier. And so, so the model that we've designed, by design, we wanted to create a model that is scalable and that can be used at a time like this in a kind of emergency situation. We think that this model is also useful just to validate manual processing.
Kenry, you're just about out of time.
Okay, great. And so we're very happy with that. And then also there are other kind of use cases like ventilator tracking that we think we can apply the model to. And so I was gonna just go over some work that we've done with our kind of larger study looking at predicting patient deterioration. And so this is where we took this modeling technique from, where we look at other observations that clinicians are that are putting into the system, including the frequency of those observations and also the actual content when you look at things like nursing notes and clinician notes. And then this is just some of the performance for that kind of higher model that that we've used, that we've created for our concern validation, both in the ICU and the acute care setting. And so we think that also that work can be used in this emergency situation also just to help decision makers in the hospital understand which patients are deteriorating. And so we plan to employ that as well. And so I mentioned before the grant funding from this project, and that's all I have. So if anyone has any questions, that'd be great. Thank you.
Thank you, Kenrick.